In this video, I will be going to assess and discuss some parts of the abdomen. So, first is observe the coloration of the skin. Normally, abdominal skin may be paler than the general skin tones because this skin is also seldom exposed to the natural elements. Abnormally, purple discoloration at the flanks indicates gray Turner signs. The yellow hue of jaundice may be more apparent on the abdomen. Next, pale to hot skin may be seen with ascites. Redness may indicate inflammation. Next, note the vascularity of the abdominal skin. Normally, scattered fine veins may be visible. Abnormally dilated veins may be seen with cirrhosis of the liver, obstruction of the inferior vena cava, portal hypertension, or ascites. Next, note any stray. Abnormally, new stray are pink or bluish in color. Old stray are silvery, white, liner, and uneven stretch marks from the past pregnancies or weight gain. Abnormally, dark bluish stray are associated with Cushing syndrome. Next, inspect for scars. Uh, Normally, pale, smooth, minimally raised old scars may be seen. Abnormally, non-healing wounds, redness, inflammation, deep regular scars may result from burns. Next, assess for lesions and rashes. Abnormally, abdominal is free from lesions or rashes. Abnormally, change in walls including size, color, and border symmetry. Bleeding walls or petache may also be abnormal. Next, inspect the umbilicus. Umbilical skin tones are similar to surrounding abdominal skin tones or even pinkish. Abnormally colon sign, bluish or purple discoloration around the umbilicus. Also, the Turner sign is a bluish or purplish discoloration on the abdominal flanks. Next, observe the umbilical location. Normally, umbilicus is midline at the lateral line. Abnormally, deviated umbilicus may be caused by pressure from a masses, enlarged organ, hernia, fluid, or scars. Next, assess contour of umbilicus. Normally, it is recessed or protruding more than 0.5 centimeter and is round or conical. Abnormally, an everted umbilicus is seen with abdominal distension. Next, inspect for abdominal contour. Normally, abdominal is flat, round, or scaphoid, usually seen in adults. Normally, a generalized protuberant or distended abdomen may be due to obesity, air, or fluid accumulation. Next is we will be going to assess the abdominal symmetry. Look at the abdomen as the client lies in a relaxed supine position. Normally, abdomen is symmetric. Abnormally, asymmetry may be seen with organ enlargement, large masses, hernia, diastasis recti, or bowel obstruction. Also, a hernia is a protrusion of the bowel through the abdominal wall. Next, inspect abdominal movement with the client breath, respiratory movement. Normally, abdominal respiratory movement may be seen, especially in male clients. Abnormally, diminished abdominal respiration or change to thoracic breathing in male clients may be reflect peritoneal irritation. Next, observe aortic pulsation. Normally, a slight pulsation of the abdominal aorta which is visible in the epigastrium, extends full length in the thin people. Normally, vigorous wide. Abnormally vigorous wide exaggerated pulsation may be seen with abdominal aortic aneurysm. Next, observe for peristaltic wave. Normally, peristaltic waves are not seen, although that may be visible in very thin people as slight ripples on the abdominal wall. Abnormally, peristaltic waves are increased and progress in a ripple-like fashion from the left upper quadrant to the right lower quadrant with intestinal obstruction. Next, auscultate for vowel sounds. Normally, a series of intermittent soft clicks and gurgles are heard at the rate of 5 to 30 per minute. Hyperactive vowel sounds referred to as borborygmus may also be heard. Abnormally, hyperactive vowel sounds that are rushing, tickling, and high pitch may be abnormal, indicating very rapid motility heard in early bowel obstruction. Next, vowel sounds may be more active over the ileocecal valve in the right lower quadrant. Normally, postoperative vowel sounds resume gradually depending on the surgery. Abnormally, decrease or absence vowel sounds, likely the absence of bowel motility, which constitutes an emergency requiring immediate referral. Next, note the intensity, pitch, and frequency of the sounds. As far as I know, there is no normal findings, but there is abnormal findings. And the abnormal finding is the increased pitch of the vowel sounds is most diagnostic of the obstruction because of the signifies intestinal distension. Next is the auscultate for vascular sounds. Upon auscultating the vascular sounds, use the stethoscope using the bed. Normally, bruits or bruit are not normally heard over the abdominal aorta or the renal iliac or the femoral arteritis. Abnormally, the bruit with systolic and diastolic components occurs when the blood flow in the artery is turbulent or obstructed. Next, listen for venous hum. Normally, venous hum is not normally heard over the epigastric and umbilical areas. Abnormally, venous hums are rare. However, an accentuated hum heard in epigastric pain or umbilical area suggested increased collateral circulation between the portal and the systemic venous system. Next is the auscultate. Auscultate for friction, rub over the liver and the spleen. Normally, no friction, rub over the liver or spleen is present. Abnormally, friction rubs are rare. Next, percussion for tone. Normally, generalized tympani predominates over the abdomen because of the air in the stomach and the intestines. Dullness is heard over the liver and the spleen. Abnormally, accentuated tympani or hyperresonance is heard over the gaseous, disten- distended abdomen. Next, percast the span on the height of the liver by determining its lower and upper border. Normally, the lower border of the liver dullness is located at the costal margin to 1 to 2 centimeter below. Normally, if you cannot find the lower border of the liver, keep in mind that the lower border of the liver dullness may be difficult to estimate when obscured by intestinal gas. Next is the to assess the lower border. Normally on the inspiration that the lower border is the liver dullness may descend from 1 to 4 centimeter below the costal margin. To assess the upper border, normally the upper border of the liver dullness is located between the left, fifth, seventh intercostal of the space. Normally, the upper border of the liver dullness may be difficult to estimate the obscured by pleural fluid of the lung consolidation.